Hello everyone, my name is Kong Shrinani and welcome to my YouTube channel Neuro Chat with AG. On this channel, I plan to cover topics that are closest to my heart and support the neurodiverse community. Topics related to neurodiversity, autism, late autism diagnosis, and autism in women and girls. I will interview thought leaders, esteemed researchers, scientists, professors, doctors, and psychologists and seek their views and updates on their latest work and research. I will also chat with parents of neurodiverse kids and adults and talk about experiences of neurodiverse individuals. Lastly, keeping inclusivity as a topmost priority, we might also discuss controversial disparate views for a collective understanding of issues and respect for diverse views. All the views and topics discussed are for informational purposes only. If you are interested in watching more quality content on this topic, please hit the subscribe button. Don't forget to press the bell icon to be notified whenever a new video is uploaded. Please also share the channel with your friends, family, and social media platforms. Thank you. Dr. Celine Saulnier is a licensed clinical psychologist with extensive expertise in neurodevelopmental disorders. She founded Neurodevelopmental Assessment and Consulting Services, NACS, where she provides specialized assessments, consultations, and guidance for individuals with autism and other developmental conditions. Dr. Saulnier is known for her clinical insight and invaluable commitment to advancing and understanding support for neurodevelopmental differences, offering invaluable resources to families, clinicals, and educational institutions. Her work emphasizes tailored, evidence-based approaches to assessment and intervention to improve her clients' outcomes and quality of life. She has co-authored Essentials of Autism Spectrum Disorders Evaluation and Assessment and Essentials of Adaptive Behavior Assessment of Neurodevelopmental Disorders. She is also an author of the Vineland Adaptive Behavior Skills, 3rd edition, one of the world's leading measures of adaptive behavior. Dr. Saulnier, welcome and thank you very much for the time today.
Thank you so much for having me. It's such a pleasure to be here.
And to jump right into it, could you tell us about your journey and what initially inspired you to pursue a career in autism research and clinical care?
Absolutely. I was a psychology undergrad major. I went to Catholic University in Washington, D.C., and many individuals who get a bachelor's in psychology know they have to go on to grad school if they want to do anything in the field. And I applied and didn't get accepted. I had no experience in what I was applying for. I hadn't, worked in research or clinical care. And my advisor said, you need to find that experience. So I moved home to Boston, and it just so happened on my street where I grew up was a residence for autistic individuals that were international. They went to a school called the Boston Hagashi School, but they lived in the residence year round. So I got a job at the residence, and that was my first exposure to autism. I worked with the young childhood division. So these were children under the age of 7 that were only seeing their families 8 weeks of the year because in their countries, there was nothing else for them. And that just broke my heart. And it just made me want to learn more about autism, kind of like your journey. I just want to know more. There has to be something better for these individuals out there. And that just motivated me to gain more experience, both clinical and research. I ended up moving back to Washington, D.C. and volunteering at the National Institutes of Health and just gaining all the experience I needed to get into grad school. And then I went to grad school specifically with an interest in autism. And I went to the University of Connecticut with Dr. Debbie Fine, who's world renowned in both autism and neuropsychology. Got my PhD in clinical psychology, and then just an hour south was the Yale Child Study Center, and I needed to do a postdoc, and ended up doing a postdoc at Yale with other world-renowned clinician scientists, Ami Klin and Fred Volkmar, and that just kind of solidified my passion for everything autism. I ended up working specifically in diagnostic evaluations, but within a research environment. When you're conducting research in autism, you have to do evaluations to confirm the autism, and that just became my specialty. And fast forward, Ami Klin in 2011 was recruited to Emory University. So he left Yale and came down here to Atlanta to direct a huge autism center called the Marcus Autism Center. And I came with him. down. Me and several colleagues came from Yale to Emory. And then I spent the next 7 years working again in clinical research at Emory and the Marcus Autism Center. And then 2018 decided to kind of do a 180 in my career and opened up my own clinic and consulting company. I'm still adjunct faculty at Emory though. So that's my journey.
You've worked with like various individuals from infants to adults in clinical and research settings. So what key differences have you observed in like diagnosing and, therapy for autism across the lifespan?
This is a loaded question because not only is the lifespan so broad, so it's very different to do an evaluation on an infant compared to an adult, but the spectrum is so broad that the diagnostic criteria, just even in my career, have broadened so tremendously that autism used to be a very distinct clinical disorder where there were deficits and delays, not only in social development, but in cognition and in language. Now it's so broad that it's a very gray area between what's neurotypical development and neurodiverse development. So many, if not the majority of autistic individuals don't have any deficits or delays in cognition and language. It's just the social vulnerabilities and the presence of the restricted and repetitive behaviors. So when we're looking to do an evaluation, that's the common thread across the lifespan, is that you're still looking for the autism diagnostic criteria, the delays in social communication and interaction, but also the presence of restricted, repetitive, and stereotype behaviors. But that's where the similarities end, because in very young children, you have much less diagnostic differentials, right? You're determining, does this child have autism? It could also maybe be a language delay, or it could be a developmental delay or emerging ADHD. There's only a handful of things it could be otherwise. But you get an adult, or even an adolescent for that matter, who's gone undiagnosed, they've now developed a whole bunch of other symptomatology because the autism has not been treated or accommodated. And so if someone can't communicate effectively with their words and with their gestures and eye contact, which is autism, then they will communicate with their behavior. They'll have screaming, throw down fits and tantrums. They might be aggressive or self-injurious and hit themselves and really put themselves at risk or another person at risk. Then there's heightened anxiety, and then there's depression, and then there's behavioral dysregulation and sensory processing issues, and the list goes on and on. So when I'm evaluating an adult, now it's almost like the autism criteria, those social vulnerabilities and the restricted and repetitive behaviors come secondary to weeding out all of those other factors and co-occurring conditions. And it's really complex, and it can be hard to determine and identify. And what's challenging and frustrating for me and for every clinician in the field is that it still comes down to just our clinical judgment. There is no test to diagnose autism. It really is just, do we think it's autism based on our knowledge and expertise and all of the information we're gathering and all the tools we're using? And that's a lot of responsibility, and we won't always get it right, even in an infant, I could get it wrong and say, they don't have autism and they do, or I could say they do have autism and they don't. And that's just the nature of the process.
What are the most important elements to consider when evaluating individuals for autism, like particularly in early childhood, like you mentioned? So what do you look for?
Well, first and foremost, I want to make sure that the social vulnerabilities that we're seeing, and that's social communication, both verbal and nonverbal, right? We take for granted that when we communicate, we are naturally integrating our speech with our eye contact, gestures, facial expressions. All of that is important in communication. And in very young children with autism, it's those very skills that are often delayed. Even in the first year of life, you won't see a child gesturing as frequently as a neurotypical infant of the same age would be gesturing, would be looking at another person, would be integrating the eye contact, the gesture, and the vocalization. Even if they're speech delayed, a child is still going to vocalize and try to get their needs met. A child with autism won't do that. They might just seek out what they want or need on their own, or they just scream and have a fit, but there's no directed attempt to communicate where that frustration is coming from. And so that would be what I'm assessing. And also, one of the most important parts of any diagnostic evaluation throughout the lifespan is looking at the profile of skills of early cognition, or what will later be intelligence. Because if you have developmental delays or intellectual delays, like intellectual disability, you don't want to misdiagnose autism for one of those. So we'll do a developmental assessment on the infant or toddler to make sure we know that there are delays, but now we're assessing for the social communication delays on top of that, right? Because any child with delays will have social delays too. It's just that in autism, they will also be above and beyond the expected delays.
What are the challenges? Like you just mentioned about like, you know, there's no like there's not criteria, but there's like no specific test you can do to make sure someone has autism. So what are the biggest challenges in autism diagnosis that clinicians face today? And, you know, how do you think we can fix those if we can fix those?
It's probably the biggest stopgap from getting children effective services and efficient services, because the diagnostic process takes so long. And it takes so long because it's so comprehensive. Because when I was in academia, I had the benefit of working as part of a team. So I was a psychologist, but I was working alongside a speech pathologist and a either pediatrician or psychiatrist. And we could all kind of put our heads together, all observing the same child, and say, do you think it's autism? And then when it's a collective agreement, right, you feel more confident in your diagnosis. Right now, I'm in private practice. There is nobody else in this clinician and in this clinic except me. So if I am on the fence or it's a really complex case, I have no one else to turn to. So it comes down to making sure I have all of the appropriate information. And, again, with young children, you have the collateral of the parents. And if there's daycare providers, or if they're in a preschool or school, you have the teachers that can offer you information that helps inform your diagnostic opinion. But in older individuals, they might not have parents, or they're estranged from their parents and don't want to include them in the evaluation. They don't have a teacher anymore because they're out of school. And so you're only going on that person's recollection of their history. And you have to remember that autism, even if it goes undiagnosed into adulthood, is still a neurodevelopmental disorder, meaning it still evolves in the first few years of life. So the symptoms have had to be present in those first few years of life, even if they get missed. Does that make sense? So that developmental history is really critical to the diagnostic evaluation.
I have some data that I wanted to ask you about. So 1 to 4 for diagnosis between girls versus boys.
Yeah.
So I would imagine diagnosis for girls becomes crucial as they miss early interventions. So what are your thoughts on, that whole situation?
Well, this has also evolved over time and even during my career, where 20 years ago, autism was so narrowly defined that a female having autism was quite rare. It was still 1 in 4. But when that one female was identified, she was more likely to be more severely affected than males. And if we look at this from a genetic standpoint and looked at the genetic mutations, the females had larger mutations than the males to meet the same diagnostic criteria. So there was some protective effect happening in the females, meaning they had to have a harder genetic hit to present with the symptoms. Now that we've broadened the diagnostic criteria and most individuals don't have any cognitive or language delays, The females who have intact cognition and language are more socially motivated, more socially reciprocal and interactive, and falling sub threshold of our diagnostic criteria, but they still have the social disability. So what happens is that they look better than the males, so they're not meeting criteria, not getting diagnosed, but they're struggling. So by the time they get to middle school age and especially high school age, when interactions are so nuanced and they can't keep pace with the subtle nuances, they get really anxious and depressed. And then that ends up causing its own problems, right? That there's a lot of co-occurring conditions with the females. And sometimes the autism symptomatology is not as severe as the depression and anxiety. And so those are things that we're looking at, and we're realizing in the field that because of this protective effect and the more subtle symptom presentation, that maybe we should have different diagnostic criteria for females. The field has just not, we haven't gotten there yet. So we have a diagnostic system from which we're sort of bound to compare the behavioral characteristics. And right now, I'll tell you, a lot of the times when I'm diagnosing females, especially older females, they are falling sub-threshold. So it's my diagnostic judgment that they meet criteria for autism, even though if you did a check mark against all of the diagnostic criteria, they might not meet them all.
With these new findings, like late diagnosis of adults increasing, so much in the past few years, um, how do you approach assessments differently for children versus adults? And I know you mentioned this earlier, but like I asked earlier, like how you look at children, how do you look at adults now, like when you're doing this diagnosis?
Yeah, I think this maybe differs from clinician to clinician. I personally, when I take on a client, I will tell that client, I'm going to involve someone else in your family. It's not just you, right? So you need to be on board with that. That if a parent, it's going to be, if there is a parent alive, I'm going to include the parent and conduct that really comprehensive developmental history. I invite the client to be present when I do that developmental history so that they can add their, report along with the parent. And, sometimes parents aren't present, so I'll take a spouse, a significant other, a roommate, or a friend. I'll just involve someone else. And then, in addition to assessing for all of the autism criteria and the IQ testing, I'm conducting assessments of adaptive behavior, which are your everyday practical skills. And those are often very delayed in autism. Even if an individual has high IQ and language, those adaptive skills are usually pretty poor. And then executive functioning, because by the time you get to adulthood, if you have an undiagnosed autism, condition going on, you probably have struggled with organization and planning and, sticky attention and all sorts of executive functioning. So I'll do assessments for that. And then social emotional. So I'm doing assessments of anxiety and depression. Some of these individuals have developed obsessive compulsive symptoms and or they've experienced trauma. So now I have to keep broadening and broadening my assessment battery to include all of these different measures to assess for all the co-occurring and overlapping symptomatology. And then ADHD, right? There's so much overlap with ADHD. Usually by adulthood, these individuals have been diagnosed with ADHD first, and then all the traditional therapies are not working. And so now the question of autism comes up. So it's much more comprehensive. I'll tell you, it takes 2 to 3 times the amount of time to conduct one of these evaluations with an adult, understandably, because just the history alone, of a 30-year-old compared to a 3-year-old, there's not much history to collect on a 3-year-old.
Just one thing that came to mind just now, something I'm curious about, but like you mentioned, with some people might have gotten diagnosed with ADHD and now they're realizing that, it's not just that. So in situations like that, does it usually end up being that they get diagnosed with both? conditions, or would you realize that it really was autism and not ADHD? That's
Well,
just an
this is
example, but
it's such an interesting question because we have a diagnostic system called the Diagnostic and Statistical Manual, the DSM, and that has all the clinical conditions with all the recipes for the symptoms that you have to meet each condition. Prior to 2013, in our fourth edition of the DSM, under the criteria for autism, there was actually a stipulation that you could not provide ADHD along with an autism diagnosis because it was just considered to be so overlapping that any individual with autism, if you think about it, had inattention, had behavioral dysregulation and impulsivity, that they would just meet criteria for ADHD anyway. And therefore, it wouldn't be so meaningful. But in 2013, with the fifth edition of our DSM, they changed that rule. And now they say, no, these are distinct conditions with a lot of overlap, but they're distinct conditions that you can provide both diagnoses. Now, many of us were doing that anyway. It's just that, now the Bible was telling us it was okay. And and I have absolutely diagnosed individuals with both when the inattention, hyperactivity, impulsivity, especially in kids, they're just all over the place, and it has nothing to do with the autism. It is truly above and beyond the social disability of autism. In adults, sometimes it comes to question whether that ADHD was a misdiagnosis along the way, that someone just missed the autism, described it as ADHD. And I really don't think that this adult, by adulthood anyway, has ADHD anymore. And it's more just the autism.
working in both research and clinical practice, how do you think we can better integrate research findings into like real world clinical settings to improve both diagnosis and care?
This is one of the reasons I did the 180 in my career and went into clinical practice, is because how frustrating it was to see years and years of research, millions of dollars in funding go into these grants that go into publications that go into a shelf and never see the light of day, right? That very few scientific studies make it into clinical practice and succeed, especially in autism. Autism intervention research is very, very messy because of all the co-occurring conditions and because there are so many different interventions. No one has just one intervention in autism. And so it kind of breaks my heart to see how little makes it over the fence. But that is a huge initiative in the autism research field. Even when you're writing a grant now, the grant funding agencies will ask the grant researchers, how are you going to make an effort to implement this into the real world, right? To cross that bridge and make it translational. And so that's happening more and more. But again, it's hard. You can really control things in a confined research lab. And then when you go to apply it in the real world, it's so messy that it doesn't have the same effect, the same impact.
You've published in so many, top autism journals and, contributed to so many major research grants. So what areas of that research do you find most exciting or promising now? And how do you see the field evolving because of that over the next few years?
Well, I just had the fortune of working with Ami Klin and people like Warren Jones and a whole bunch of cognitive neuroscientists that specialized in eye tracking technology. So Ami Klin and Warren Jones developed eye tracking technology. They started in adults and did the research all the way down to infants to see that there was enough difference in eye looking patterns between individuals with autism and neurotypical individuals that this actually was predictive of their autism even as early as 6 months of life. And long story short, even so I worked with them on this eye tracking, the development of the what is now a patent for years and years and years. They did a clinical trial and an FDA trial to look at the efficacy of the eye tracking technology in toddlers, so ages 16 to 30 months. And it just got FDA approved maybe 2 years ago. And so now there's a company called Early Tech, and the device is called Early Point, and it's an assistive diagnostic device that just based on 10 minutes of eye looking, like a toddler in a pediatrician office can watch, videos on this particular device for 10 minutes. And at the outset, there's a printed report that says whether or not that toddler has autism. And that's a biomarker, meaning that is saying that it's autism based on the child's own behavior. It's not based on any observation from another person, right? So it's more accurate. And this kind of technology, these biomarkers, more and more are going to come into play, taking the onus off of people like me to make that diagnostic judgment call. And that's where the field's going, whether it's eye tracking, neuroimaging, genetics. At some point, we're going to do away with having to do these comprehensive evaluations like I'm doing. The thing is, if you do the eye tracking right now, the way it is with the FDA, you still have to do some additional testing to ensure, to confirm the autism and to get the insurance reimbursement. But it really streamlines that process and can fast track these babies right into treatment and intervention to get the appropriate accommodations they need much faster than if we didn't have it. So I find that just so exciting, from obviously a biased perspective, because I worked on the project for so long. To see it come to fruition is just phenomenal.
How did you establish neurodevelopmental assessment and consulting services? And what are your primary goals?
Well, I established it out of a necessity of literally, okay, I just quit my job. Now what? I just decided I wanted to make a big change in my life. I had two daughters. Academia doesn't really lend itself to a good quality of life, especially as a working mother, because you are working 24/7. There are no times off in academia. And I just wanted a different quality of life. So my alternative was to go into private practice. Thankfully, at that stage in my career, I had already been in my career for 20 years. I had enough connections in academia, the industry, grant, proposals and things like that, that I could still keep a foot in academia through consulting. And then I didn't have to rely 100% on clinical practice. And that's where the mouthful of the name came about, Neurodevelopmental Assessment and Consulting Services, NACS, because I was doing a mixture of both consulting and diagnostic evaluations. And fast forward 6 years, because I opened it up in 2018, I still probably do about 50-50. That 50% of my time is consulting and 50% of my time is private practice.
Given your extensive experience in neurodevelopmental assessment, what are some of the most critical aspects of an accurate assessment for autism?
That's a loaded question. I think if there's a gold standard for an evaluation, it's going to involve a developmental or cognitive assessment, right? That profile skills. I'm less concerned about what's your IQ, but what is your profile strengths and weaknesses within your intellectual profile? Because autism, you're going to see peaks and valleys and a whole bunch of gaps and not evenly well-developed skills. So that plus the adaptive behavior assessment, because that's your everyday practical skills. For whatever reason in autism, probably because of the social disability, when you're not monitoring your social world, you're not modeling your social world. And we learn most of our everyday practical skills through watching other people. We watch our parents, our siblings, siblings, our friends, everybody, and we assimilate and accommodate of how to act in our society. So when you don't do that, you have delays in your adaptive skills. So an adaptive assessment, the cognitive assessment, the assessment of all the autism criteria, the gold standards, we have a few in our field, the Autism Diagnostic Observation Schedule, or the ADOS. The For the developmental history, there's the Autism Diagnostic Interview, the ADI. And then there are some other rating scales that you're giving parents and teachers and things like that. But I would say those are the critical ones for young children, a speech, language, and communication evaluation, because we're talking about a communication disorder. And it's really important to have that expertise of a speech pathologist on board. And then, going from there, you're adding on based on the person in front of you, right? And what their needs are. If there's anxiety, if there's depression, if there's OCD, if there's this, you're going to add on the different components.
What are your thoughts on how early and accurate assessments impact like long-term outcomes for neurodiverse individuals?
Well, we just have research time and again telling us that the earlier the diagnosis and the earlier the intervention, the better the outcome. It really all depends on the quality of that intervention, though, right? We can reliably diagnose autism by 18 to 24 months of age, earlier in really pronounced cases. Yet the average age of diagnosis in the United States is well over the age of 4, meaning that we're not even doing a good job here in the US of detecting autism when it can be detected. And now we have that gap widening into school age and adulthood for some individuals. And so it just becomes critical to know the risk signs, because with 1 in 36 individuals, we're talking about over 2% of the population has autism right now, that everybody should have some understanding of what autism is to be able to say, maybe that kid should be evaluated and not take a wait and see approach, right? So many pediatricians just say, oh, he's a late talker. Let's look at him in another 6 months. Give it a year. He's a boy. And we can't do that. I'd rather be safe than sorry and do the evaluation and have these biomarkers that in 10 minutes we can at least have an idea, right? That yes, this child should be more closely evaluated and streamlined into intervention. And really with intervention, we're trying to remediate the debilitating symptoms, right? If a child can't talk because they have no speech, we want to teach them speech. If they have no behavioral regulation skills and they're going to hit and bite and scream and hurt themselves or someone else, we want to remediate that. The autism is just social diversity, right? It's navigating the social world differently. So it's giving accommodations, but also providing environmental modifications, right? Having the world be more accepting of these neurodifferences. And I think that's more easy to do when the child is younger, because you haven't had time to build all of these co-occurring conditions. It's harder to undo the self-injury and the aggression and the anxiety and the depression and the suicidality and all that comes later if you intervene early.
How do you see the future of neurodevelopmental assessment evolving?
Hopefully with biomarkers, hopefully that we don't have to rely on clinical judgment anymore, and that our job is really to do the evaluation to look at the profile, because knowing someone has autism doesn't tell you much about that person's profile, strengths, and vulnerabilities, right? And there's a saying in the field, and I'm sure if you've interviewed Dr. Grandin and everybody, in this field, you've probably heard this ad nauseum. If you've seen one person with autism, you've seen one person with autism. So just the biomarker saying, yes, this is autism only tells you so much. We still have to know the profile of strengths and weaknesses of language and communication and executive functioning and cognition and what have you. So I'm not there'll always be a need for that testing, but to take the onus of that diagnostic judgment call, I would very happily give that to a biomarker.
Is there any advice you'd like to give to parents or individuals who suspect they or a loved one maybe neurodivergent and are considering an assessment?
Well, so the diagnostic label really comes down to a, a vehicle for getting services. That's all it is, right? It's a label that gets you services. So I would first and foremost say don't be afraid of the label. There is still a stigma for many people with not just autism, with many different conditions. And that's unfortunate because we really do want autism to be seen as neurodiversity, different, not disordered. And and yet, what are those debilitating symptoms that we can alleviate with the label that then gets us the services, right? For an adult, that could be that they're about to lose their job, or maybe they were already fired from their job because they said or did something inappropriate or was misunderstood by people in the workplace. For young children, they're often kicked out of schools because of their behavioral dysregulation. So they're being punished for their disability rather than supported for their disability. So that's what I would say. It's really all about, don't be afraid of the label. It's really all about getting the needs met. And, we can always call it something else. We just want to identify what those needs are so that we can help every individual be optimize their potential for success.
For young professionals interested in neurodevelopmental psychology, what skills or areas of focus would you suggest they develop?
If they're doing clinical work, you need to have a clinical acumen, right? That clinical intuition of working with another person, whether it's in a therapeutic context or in the diagnostic assessment process. That's hard to teach. That just comes with people naturally. Kind of like when you were telling your story, you so naturally just empathized with these individuals when you were interacting with them and wanted to do something more. The things that you teach to prepare, right, in your career are about the varying profiles, the interweaving symptomatology, knowing about the lifespan. So to know about autism, you have to be well versed in typical development because you need to know when typical development's going awry. And so just being kind of well rounded in that area. Also, just stay evidence based because in autism, there is a lot of discussion about things that are not scientifically vetted, right? And TikTok, social media, you go anywhere on the internet and you're going to get misinformation about autism. And there's even research showing that only 27% of the information on TikTok, for example, is accurate about autism. And so making sure that people who are going into the field, even if it's more of a clinical degree, understanding the importance of science and being knowledgeable of the research in the field and what is accurate and what compared to what's misinformation.
Ms. Saulnier, thank you so much for taking the time to share your insights and expertise in this interview. Um, I can like your dedication to advancing the field of assessment and your passion for supporting neurodiverse individuals is really inspiring, and I'm grateful for this opportunity to learn from your experience and perspective. Thank you so much.
Thank you. It was such a pleasure. And I just get excited that there are individuals like you that are going to move the field forward.
Thank you.